two extraordinary nurses here. So we have Julia Taylor, MBE, Macmillan Consultant Nurse Urology, Clinical Governance Lead Urology, Salford Royal NHS Foundation Trust, and past President of the British Association for Urological Nurses. And we have Heather Janes, the Urology Oncology Nurse, the Urology Oncology Clinical Nurse Specialist at Betsy Caldwell University Health Board. I'm sure Heather, you'll tell me how to pronounce that correctly. So if we can move to the next slide, if I can ask you to introduce yourselves and then speak about some of the findings in the Exemplar Report and how they reflect with your own personal experiences.
Lovely. Thanks very much, Lydia. Well, I think you've already introduced ourselves by our long titles and things that we do. But really for me, I'm a nurse who started, well, over 20 years ago, I was asked to develop specialist practice in urology. And at that time, I just remember that patients were coming out after being given bladder cancer diagnosis in tears, perhaps, as we've alluded to earlier on, that not having been delivered in a really good experience and leaving the department. And I remember reflecting at that time that if I was going to start with anything, I'd start with bladder cancer. And yes, we've come a long way, but we've got so much further to go. So I'm delighted to be able to be here and share some of my own personal experiences from that point of view. And with my other hat on as a previous born president, really having a feel for what the experiences of nurses nationally who are members of the British Association of Urology Nurses. And I suppose for me, it's another great opportunity listening to the experience of working with Fight Bladder Cancer, because like many of the others who've alluded to it, I really first met anybody from Fight Bladder Cancer when they won the Best Prize Award at our Bourne conference. And that was really about the way in which they interacted with all the nurses, and they were really keen and very clear about the importance of education development for nurses and the impact that CNSs had for patients in their pathway. So those are my two hats. And what I'm going to do is hand over to Heather, and she's going to introduce herself, and she's going to start with a couple of key findings.
Thank you. And well, as Julia said, Lydia's really already introduced us. And it's Betsy Cadwallader. Apparently the correct pronunciation. And I'm based at Glenclwyd. So actually we're made up of 3 general hospitals in North Wales. And they were all in the same health board. We're quite geographically quite far apart. And as far as bladder cancer is concerned, we are lucky now to have a new bladder cancer specialist doctor based not at the hospital I work out, but over in Bangor. And so we're able to do those cystectomy operations back in North Wales, which we haven't been able to do for quite a few years. So I'm just based at a relatively small sort of general hospital up in North Wales. So that's me. So just looking at this, I mean, we can really see from this report that clinical nurse specialists do play a vital part in the patient's experience and the support that patients receive in their cancer journey. And unfortunately, although it was recommended many years ago that all cancer patients should have access to a specialist nurse, we can see from this study that unfortunately for bladder cancer patients, that's not always the case, and there is still a bit of a postcode lottery on whether patients do have access to the specialist nurse. So one of the roles of the I'm going to call them CNSs, otherwise it gets a bit long-winded, clinical nurse specialists, is that they help sort of coordinate the patient's care and provide the patient with a named person that they can contact if they've got any concerns or worries. Because we know that every time a bladder cancer patient has a check cystoscopy or when they're waiting for histology, those waits generate stress and anxiety, not just for them, but also for their friends and family. And so without the support, they often don't know who to contact and are left feeling quite alone. They're having to sort of negotiate with secretaries and booking clerks and trying to get answers on appointments and what's happening. We know that capacity issues at many hospitals mean that appointments, unfortunately, aren't always timely and as we would always like. And we know that this has definitely been exacerbated during COVID, with many hospitals having to reduce the number of patients that they've seen and reduce the number of clinics. I know in my own hospital, we've gone from doing 5 lists of 10 patients having flexible cystoscopies a week down to only 3 lists with only 7 patients on each. So we've gone from a capacity of 50 check cystoscopies a week or cystoscopies a week down to 21. So it's quite easy to see how that's caused massive delays for bladder cancer patients, and I'm sure my hospital's not alone in that. We have managed to continue with all our rapid access clinics, all those haematuria clinics right through COVID. They've continued, but it's those check cystoscopies that unfortunately have suffered. Also, as a CNS, I was redeployed for several weeks to work as a ward nurse due to staff sicknesses and self-isolation needs. And so when patients did have procedures cancelled and things, there wasn't that support there. And I know that since I've been back in my role, I have been able to advocate for those patients and help prioritise those patients. So for the booking staff and the staff that are just listing patients, one check cystoscopy is exactly the same as another, whereas we know that actually there's a big difference in patients' grade, stage of cancer and risk priorities. So being able to have a CNS being involved enables patients to be prioritised on clinical need, really, rather than just the name of the procedure. And also it's having a CNS also enables the patients to be more understanding of when they have those warning symptoms. So if the patients have developed blood in the urine again, they know that they can contact and who to contact to then fast track them into the system and get an extra one put on a list somewhere maybe or squeeze them in somehow. Whereas if they don't know who to call and what to do about that, or they'll just phone the secretary will look on the system and say, well, you're already on the list for it, and not take it any further. So I think that's really important. Julia's going to discuss. Over to you.
Okay. Thanks, Heather. So the next issue is really about the CNS's reporting issues about high caseloads. And I think, Heather's already alluded to this time during COVID, where perhaps certainly our team were looking at triaging and prioritising patients who are actually in that surveillance group. So I know certainly, I think my list was over 350 patients that I needed to go through and communicate with. And certainly I got a sense of how valuable they felt that was. But because they I think they were surprised that we were still working, that we weren't doing, all COVID related things, and that, recognizing that they were actually a priority to us. But again, in normal circumstances without a pandemic, what you've got really is a variable specialist nursing provision across the country. Hugh alluded to it earlier on. He talked about, the issues around getting it right for prostate cancer patients. But actually, this urological nursing workforce that we're talking about usually would supply, being a key worker, the CNS for not just bladder cancer, but prostate cancer, renal cancer, testicular cancer. So unlike some other cancers like breast cancer, you would be a breast cancer nurse. Here, there's around about 33 different titles for urological nurses. And so it's very unclear, really, about the workforce, what sort of caseloads they've got. And they also speak to having low resources. And typically that, when nurses talk to me about that, it's about not having any administrative staff to support them, any secretarial support. That's usually on the back of a secretary who might be, working for one of their clinicians. And with nurses doing lots of nurse-led clinics and many of looking at delivering holistic needs assessments, they really need the support of secretarial and administrative teams as well. And the next point is about an ageing population, and I will put my hand up. I am part of that ageing population of senior CNSs. And I think what's really important to say about, I'm not being defensive, honestly, but to develop expert exemplar nurses, you have to invest in them, and that takes some time. And there's often a very poor understanding of what actually CNSs do. I think for me, interestingly, there was a review that was undertaken and born. I was involved in that. There was something like 400 urology nurses that responded to it, and it was back in 2014, and it was looking particularly with a focus on prostate cancer at that time. And what they identified was that almost 50% of those people who were nurses that were surveyed, almost 50% of those by 2024 were going to leave their role, and most of that was around retirement. So unfortunately then the new specialist workforce, if you're not succession planning your team, it's not being developed to take their place. And again, with the impact of COVID, there remains a huge void then in the nursing workforce nationally. So it's something that we really need to consider and address. And so that really brings me to that final part about what causes this lack of clarity that contributes to fewer nurses coming into the CNS to become a CNS. Well, the first national review in England by Getting It Right First Time, which is led by NHS Improvements, identified the variance around developing medical staff in these areas and nursing CNSs from being staff nurses to advanced practitioners, consultant nurses, etc. And one of their first recommendation was that we needed to develop an educational framework for urology nurses so that they know how to develop into these posts and they know what sort of training they need access to, and make sure that that was accessible, high quality training in the future. Shall we go on to the next slide? Now we're going to just look at the summary of recommendations. Thanks. So the first one really looks at the current number of nurses who work in bladder cancer. We really need to understand where they are, who they are. We need to understand more about their work, their caseloads, the nature of the activity that they undertake, and the needs of that specialist group of urology, uro-oncology nurses, particularly with a particular focus on bladder cancer. Interestingly, again, when we looked at the prostate cancer workforce, and again, people would recognise prostate cancer, and there was I think somebody said before, I think it was Johnston that said before, this idea that it's the people like Fight Bladder Cancer, it's the charities really that drive this forward. But when they did that review of the workforce, the prostate cancer nurses only made up a meagre 2% of the UK specialist nursing population. And that's very similar to rare cancers. And I think we'd all say that nobody would see prostate cancer, for example, as a rare cancer. So there needs to be parity and access. We need to reduce that variation, increase the investment in CNSs and the teams that support them, so that every patient has, as Heather said, access to CNSs throughout their experience, actually when they need it. Heather?
Yeah, so it's really important that not only do the patients with bladder cancer have access to a CNS, but that also that those CNSs are well trained and knowledgeable. And as Julia was saying, there's such a wide variety of roles for nurses caring for bladder cancer patients in each department. Each sort of hospital and department kind of needs to decide on the best skill mix to serve their own individual community based on the skills of the nurses. It's like when I was chatting to Julia the other day about our sort of respective hospitals. Julia was saying about her sort of team of nurses that she's got and support staff. And obviously that's quite different working in a sort of a big tertiary centre than it is in a small general centre. I've got one full-time colleague and part-time, and we cover all the urology cancers between us. So as Julia was saying, we need to understand sort of what nurses we've got out there that work with bladder cancers, and sort of what to understand what nurses we need to have sort of more comparity with such as breast cancers, where I know we've got 2 or 3 breast cancer nurses in our hospital. So why is there only 1.5 of us for all of the urology cancers? It doesn't really make sense. And sort of moving on a little bit as well there, sort of one thing that everybody agrees on is that all professionals should have access to high quality training to support bladder cancer specialists in order to be able to provide that high quality care for patients. And patients who attend small local hospitals shouldn't receive a poorer level of care or support. The only difference should be is that they might have to travel to a different hospital for certain parts of the treatment, such as if they need a cystectomy or if they need radiotherapy. But all the aspects of care that they receive should be the same. And it's like sort of Hugh and Johnson was saying earlier, it's that parity across the UK where people should have the expect to experience the same pathway wherever they live in the UK. But CNSs in those smaller hospitals also need to have the same training opportunities, but they need those training opportunities maybe outside their own organisations in order to complement in-house training to ensure they're able to offer that high quality care. I think this is something where the sort of British Association of Urology Surgeon Nurses Born is in an ideal position to offer sort of networking opportunities to meet and learn from more experienced nurses, sort of such as Julia here, and also to help sort of develop recognised training programmes. I know Bourne have done a lot of work with training programmes such as the flexible cystoscopy workshops and things like that, and also at the annual conference where they give opportunities to network with other nurses across the UK, and also to meet Fight Bladder Cancer, and that's where I first met Fight Bladder Cancer and found out what they could offer my patients. So I've been able to signpost my patients to the support that they offer as well, which then gives people more equal access, really, I guess, to that support, because anybody in the UK can refer to yourselves. But it's getting that out there and getting that known to the professionals so that all patients can have access to that. Back over to you, Julie, for the last bit.
Yeah, so I think, we need to call on national and local NHS leaders to support that sort of reduction in variance in training provision. I think it's also important that we understand what the capabilities, so that we can clearly articulate what the role of the CNS is. And certainly, the importance of being able to take up clinical supervision, how nurses actually become CNSs, how they develop their roles, things like relevance to practice of leadership and research, that they are clearly key component parts of CNSs' roles. And again, it's how they get access and recognition that's part of what they do. And then this is going to require some support about championing existing training. I think Heather's already alluded to some of the sessions, the educational events and sessions that we can facilitate through Bourne, either study days or the national conference. Clearly, COVID is having a huge impact on charities' ability to do that. So we need to really engender some change about how we can actually get that delivered consistently, across the country, and really identify what those educational gaps are and how we're going to fund those and new educational programs. Okay, shall we just move on to the areas for next slide? Thank you. So, really thinking about further research and exploring what we can do. Clearly, the bladder cancer community and national policy makers should invest in opportunities to grow this workforce, especially the CNSs. And I suppose, again, just reaffirm the identifying their capabilities, the role outlines for those other people that can support, like cancer navigators, band 4 support, to be able to assist the CNS so that they can actually do the important work of a CNS. You know, sometimes it's helpful at the moment just to have somebody that can help, like the cancer navigators, to help initiate and record some of the personalised care and support planning. It's really important that the CNSs are doing holistic needs assessments with patients, that, you know, having experience of bladder cancer is not just about what's going on in your bladder, whether that be surveillance or whether that be that you've had major surgery. It's about a lot more. It's about looking at that individual and listening to the whole of their needs, whether that be about the challenges they've got in sharing what's going on with their family members, and a whole, I won't even start to talk about the whole gamut of different challenges that you have on your journey. Heather?
Yeah, sort of the value of expanding nursing roles focused on patients in the community was one of the things that it was picked up in this study, and you know, some patients were saying that they felt a lack of support post cystectomy, especially when they went home from hospital. I think some further research should be undertaken to sort of assess exactly what the needs of these patients are, and it's like we were talking earlier, it's about having that sort of gold standard of the patient pathway and what everybody sort of should be able to expect. So drawing up guidelines so that that there is a clear pathway that all patients should receive. Like many parts of the patient's journey, it's quite varied across the country. Some patients are offered sort of specialised follow-up by urology, specialist urology stoma nurses with specific interest in bladder cancer, and others are cared for mainly by sort of colorectal nurses who look after patients with stomas and will do the bladders as well, but don't have that specific interest. Sort of my own experience when I first started working in urology, quite a few years ago now, about 25 years ago, I worked in a big tertiary centre, and the year that I left, which was 1999, we did 50 cystectomies on the ward that I worked, just in that 1 year. Whereas in my current hospital, we've had 4 in the last 2 years. So you can see that it's quite going to be different, but it's trying to put standards in place of what patients should experience to try and make sure that they are getting that support. But I think a bit more research is probably needed on this. So it's, you know, it's obvious that the experience of the stoma nurses are going to be different depending on where they work. But if we have that sort of gold standard and that clear patient pathway, we'll have something to measure it about, something to aim for, and hopefully that will help ensure patients get good access to support in the community from wherever they live. And then sort of moving on to the next point about the importance of different sort of subspecialties, which I know Julie's already mentioned, really about needing to grow the workforce of those involved with patients, with staff caring for patients with bladder cancer. And it is really important to be aware of all the different roles of nurses and the different subspecialties within urology, and we've discussed about staff looking after all those different urology cancers, whereas some specialist nurses just concentrate on bladder cancer. And obviously the remit of CNSs is going to look different in different hospitals depending on your patient population, and there isn't really much way of getting around that. That's always going to be the way it is. But certainly in the major centres, I think it is important that all of those major centres do have a lead bladder cancer specialist nurse, and even in the smaller hospitals, it's important that you have a specialist nurse with a specific interest in bladder cancer, even if they cover other cancers as well, that you have one nurse sort of driving improvements for bladder cancer patients with that specific interest. I think that is sort of really important. But obviously we need to ascertain how many specialist nurses we need and what the optimum number of patients each specialist nurse should be looking after, but without understanding the different roles of the nurses, that's difficult to do. So that's something that maybe Fight Bladder Cancer could look at working with others in the community, just to try and work out that, so we can push for growing the workforce like was already discussed. Back over to you, Julie.
Yeah, I think certainly the discussion earlier about having the exemplar pathway in place would potentially allow us to identify the numbers of patients who then go through that pathway, and that the whole purpose of having that pathway is that at each point in that pathway you can identify where the essential component parts of the CNS role is. So that's how I would expect that would happen. I think when we talk about additional demand generated by improvements, sometimes you can make an improvement with actually not having to have more resource. So I think that there are some opportunities there potentially. But again, also earlier on, we talked about the more that we raise the profile. So we talked about the Blood in the Pea campaign. That's certainly, so there'll be when you look at that through different lenses. So the lens of the CNS would be, it's a really good thing, it's really important, but oh my goodness, how am I going to be able to cope with the impact? Because we saw a doubling of our patients who came through the hematuria clinic on the last campaign, and I wouldn't expect anything less this time, along with the COVID recovery. So it's something that we really do need to pay attention to, and consider how we can actually grow that bladder cancer workforce. Heather was talking about, probably sounded a little bit jealous because we were sort of comparing our teams, as I said, but I've got to take her back, because 20 years ago there was me being given a year to develop specialist practice, and now in terms of keeping succession plan in mind, we have myself, I manage all the specialist nurses, and we've got 4 uro-oncology specialist nurses, we've got 2 benign specialist nurses, and a band 5 who, again, these are the opportunities to develop your junior nurses into CNSs for the future. And I think that's because we've lost our urology ward base, which is where our nurses would really start to learn. And I think, again, earlier we talked about no nurses on the ward. I think it was Dorothy said no nurses on the ward understood anything about bladder cancer. And I think that's a poor show. And I think part of that then is our response. So our CNSs go out onto the wards to see patients, so that a patient shouldn't have to have that experience. Yeah. Okay, so next slide. I think now I'm duty bound to hand this part of the session over to Lydia. And thanks very much.
Thank you, Julia. Thank you, Heather, for sharing your insights and your experiences. It's extremely valuable. So now we open it up to the wider community. Do you have any questions for the speakers? What are your thoughts on the recommendations? How can we advocate as a community for implementation of the recommendations? And what should our next steps be in those areas that require further research and exploration? So we have one question from Matt here that says, are there particular challenges faced by urology CNSs in covering a wide range of cancers and diseases? And how does this impact on capacity in meeting the needs of bladder cancer patients?
So, well, shall I speak first?
Go on, yeah.
I think that there are huge challenges because of the number of patients that are coming through. So again, I know nationally when nurses are talking about this, where we know where patients are and they're coming back, we've discussed them through the MDT, and they're coming into the oncology clinic, where we have multidisciplinary teams set up to have discussions with them. Then the patients will always know that they then have access to the CNSs. Where we have our one-stop clinics, then patients will have access to the CNSs, because we would always have a nurse who had that expert knowledge there should the patients that come through have a suspected diagnosis of bladder cancer, and that would be their first point of contact with them. Sometimes, again, because it relates to capacity, and certainly this has really been made very challenging with COVID because you can't see as many patients in the same footprint because of social distancing. Then patients will be put on other clinics, and some of those other clinics then won't have aligned key workers because they might be general clinics. So there's a potential that patients then won't get seen at diagnosis. And it relies on everybody knowing where the CNSs are, or making sure that they've dropped a line onto the CNS email, that sort of thing. So again, I think I would come back to the idea that Hugh said, that setting the expectations around an exemplar pathway is that this is how you must do it, that you have to have access. And as soon as you raise that profile and it's a requirement, then that's where we can use that ourselves to be able to influence how we grow our workforce. Because certainly with the experience I've got in growing my team, where we've had national guidelines, where we've had best practice, that's where we've been able to make the biggest impact. And we've certainly seen that in prostate cancer, and I'd see no reason at all why we can't do that in bladder cancer.
Yeah, I think I would echo that. I know when I started up the support group for bladder patients in my local hospital, and I did a bit of a survey with the patients that were coming along, I think that the time that they highlighted that it was the most stressful was that initial time between coming to the hematuria clinic or rapid access clinic and having the results of that, of their TURBT. And still, unfortunately, some registrars are really good and bleep us if they've got a patient with a suspected ones, or grab us out the office, and we'll come and meet the patients then, and they get that support right from the start. And some doctors, the first you know about it is when the secretary dumps a histology result on your notes and says, oh, the doctor's asked you to ring them, and you don't, it's the first time you've seen the name, you don't know anything about the patient, and this patient's obviously been through the system, but nobody's told you about them. So it's that if that pathway was clearer and set out, it would enable patients to get, as Julia said, you've got something to benchmark, something to aim for. And although we've tried to educate the doctors that do the clinics, because there's only 1.5 of us, it's not possible for us to be there for every. Our clinics aren't hematuria clinics, they're rapid access clinics, so they're any urology urgent suspected cancers. So they're meant to tell us if they've got somebody, but they don't always. So yeah.
Thank you. I think we have a question from Johnston.
All right. I think Heather's actually already partially answered it, but it's to both Julia and Heather, because I was really pleased with their presentation, and particularly the last point, because obviously you heard me talking about breaking bad news, and I was really pleased to hear that Heather said that she would often be called to patients, and I feel that probably, I don't know if there's scope for creating that as good practice, particularly in the one-stop shop hematuria clinics or bladder cancer clinics, that where a patient's been identified as possibly having bladder cancer, they should start the relationship at that time with a CNS specialist in bladder cancer. I don't know if the workforce can deal with that, but perhaps if there was a gold standard advice that should happen, that would at least be a starting point.
Yeah, I'd agree with that. I think certainly with the emergence of urology investigations units and trying to do one-stop shops, in that sort of setting, we found it's much easier when you've got a urology investigations unit, because you've got everybody in one space. And when we've done our job planning, again, I've always given the importance around where there are one-stop clinics going on that a uro-oncology nurse is assigned to that. So but you can still be efficient in that, because they're not sitting there just waiting. They can be doing other parts of their role and doing their administration, that sort of thing. And then when called upon, they're accessible to the patients. And that's the feedback that patients give us, that is the most scary time, isn't it? When you've been given a suspected diagnosis, you came, all you've done is passed a bit of blood, and you weren't expecting what was going to happen next. And I think, very conscious that I often usually apply that idea that you have to have told somebody 5 times something before they've actually, remembered what you've said. And usually when you go past the front door, what you've been told just falls out, doesn't it? So and that might be just so you're getting to know somebody, understanding how they process the information they've been given, what would be the best way in terms of communication. Do we need to set up translating services? Can we do that over the phone? Do people prefer face-to-face? All of those other things we'd have to consider, especially during these COVID times.
Johnson, what are your thoughts on that?
Yes, absolutely. Well, even from my personal experience, the communication that I got, I think, wasn't helped by the fact that I was a senior doctor, and the clinician that was dealing with me felt uneasy about that. But the minute I had that diagnosis, I just wanted to be a patient. So that was what made it different. And so somebody like Heather or Julia taking me over at that point would have been fantastic. Basically.
Yeah, have an experience of having different medical professionals. I think that the important thing that we do as nurses is not make any assumptions. So, like, i.e., just because you're a GP, you know everything. Because just because I'm a nurse, I don't know everything. It's Absolutely. That sort of, isn't it? And really listening. I think that's what's important about the concerns checklist, the personalised care planning, is really understanding who you are as an individual and what's going on for you this moment in time.
Well, no, you get challenging patients, and I probably was a challenging patient, and I was fully aware of what the NICE guidelines were, and knew what my treatment pathway was going to be, and I was likely to have a radical cystectomy, and there was nobody there to answer that question at that time. And I know it's something that you and I have discussed before about, crucially, the diagnosis of a bladder cancer patient could be made by somebody who is not specializing in bladder cancer. They could be a general urologist or gynecologist, or so that's where the pathway is crucial in getting the right person there at the right time.
Yeah, and I think it's important as well as we hear more about developing the workforce. So that's a broad term, where we're also looking at physicians associates and people with lots of other titles. Again, we need to be able to draw out what the capabilities and competencies are of the healthcare professionals that you're interacting with, whether that be Hugh and his great experience in bladder cancer, or or me face to face when you've had your first diagnosis.
And I would sort of go along with all those comments, which is that I think the most important thing is to have a team that looks after, for example, patients with bladder cancer, and that you all, if possible, are all working in the same vicinity, because it's all that kind of informal discussions and so on and so forth. In practice, once you have a team, the roles of the people within the team are sort of almost irrelevant, because all of us can hopefully do all the discussions. And I think in terms of going back to the issue of breaking bad news, it's much better that someone from the team does it, and who in that team does it doesn't really matter. But, you need to have that kind of stability of people being there, working with each other for a number of years. And then if you have that, it tends to sort of solve many of the problems. So I certainly agree that these are not discussions to be putting on a general outpatient urology for someone who doesn't really deal with these things to deal with. It should be someone, but who that person is, I don't think really makes much difference.
Thank you, Hugh. And I think, Tracy, you've also got a question?
Yes, this is tricky, but it's something that I've encountered in a number of places and actually BAM conferences, actually. So there can be a general perception amongst young trainee nurses and those just starting out that bladder cancer is just not cool and it's not interesting, and they'd rather go and learn about prostate cancer. And as we really obviously actively need to engage with the next generation of bladder cancer nurse specialists, I wondered if you had any insight into what we can do to change that, because certainly prostate cancer 20 years ago was in a very similar position. You know, nurses weren't taking it as a specialism, but given the challenges that we all face with bladder cancer, you know, and from all you said, that's obviously a prime consideration. So I just wondered what your thoughts were on that.
It's a difficult one to, I suppose, for me to answer, because I've always been really interested in bladder cancer and I can't understand why anybody wouldn't want to work with bladder cancer patients. I think from a nurse's point of view, it's such a varied specialism with bladder cancer, with such a variety of patients and variety of diagnoses within that sort of umbrella of bladder cancer. It is, you know, very interesting and you know, especially interesting with the new developments in the oncology side of bladder cancer and those treatments and sort of learning more about those, which is still relatively new to me in my current post. I've only been a specialist nurse for about 4 years now. So coming from a very surgical side of things, I wasn't really that aware of the oncology side of things. So I guess I think the difficulty with all urology cancers is, I think, as Julia alluded to earlier, is the lack of urology wards that we have now, compared to sort of say 20 years ago, when each hospital had a urology ward, and some of the big centres had several urology wards, and we've seen those urology wards reduce and reduce. Part of that is because we've got much better at doing day case surgery and much better at not keeping patients in for as long. But what that has meant is that those urology wards have become shared wards with other specialties, and we've lost that sort of pure urology nurse that we had kind of 10 years ago, really. So I'm not sure as the answer is how we kind of sort of infuse it. I think though having sort of a clear definition of the roles that are available within urology nurses will do something to help promote and inspire junior nurses to want to go down the route of being a bladder CNS.
Yeah.
If you want to add to that, Julia.
Well, I suppose that's the challenge for us, isn't it? Not having urology wards where we particularly would have, you know, been able to have direct access with nurses who are caring for bladder cancer patients, and then being able to, you know, be those mentors and inspirational leaders with relation to what it means for them and looking at it from a career perspective. So, I mean, we continue to inspire our students, you know, as they come through, and as you've alluded to, Tracy, that certainly as I became president, I saw that difference, that variance between the access to prostate cancer CNSs and bladder cancer CNSs, and that's why we, you know, obviously raised the profile and started contributing to the first round table that we did. So I think it's really important for us to continue doing these sorts of things, and I think this piece of work that you've done is, you know, is excellent to enable us to raise that profile. As one of the recommendations, clearly what we need for nurses is developing that educational framework for urology nurses, so that then not only if they feel a bit inspired, actually we as a profession and other healthcare professionals and other charities can articulate what is the role of the nurse, what's the impact that it makes, and how to access education. So that's that first part. And then the second part is actually enabling equitable access for nurses to access education, so that then they can, you know, develop through their career framework and have, you know, bladder cancer at the heart of it. I don't agree that it's not a sexy thing, though, you know, really. I know that I'd say that, but I think, you know, and working in partnership is really important. And every part of, I say to every nurse that, you know, the 4 elements that they need to have at the heart of their practice: leadership, education, audit, and research. And research is really a key element for them to to be able to influence the practice, because it dynamically it shows, doesn't it, where the gaps are, and then we can look at using sort of quality improvement to carry on improving the care that we give to our patients. So I don't know, have we answered your questions, Wendy?
Yes, you have actually. And also I should say that, like, since the charity started and working with the British Association of Urological Nurses, it has just made a huge difference already. So that really does help, because by sharing your stories you can inspire people. So thank you, that was great.
Thank you.
Thank you. And so following on from that, we've outlined many different priorities for the next 12 months. So I will now launch a poll to ask all of you who are watching as panelists and as attendees, what is your top priority for the next 12 months? Where do you think that the bladder cancer community should focus in terms of ensuring that we have a good workforce? Should we map the current number of nurses and determine the optimal number of CNSs? Should we ensure that all urology CNSs have ongoing access to training and exposure to bladder cancer specialists? Should we be focusing on the fact that national and local NHS leaders should be called upon to support the reduction of variances in training provision for CNSs to ensure aspiring and current CNSs have equitable access to learning and development? Or should we focus on support and championing of existing training provisions? So I will give you a few more seconds to vote. And I will share the results here. So we have over 50% of people said the current number of nurses who work with bladder cancer patients should be understood, and the optimal number of bladder cancer CNSs should be determined. So mapping the workforce and then understanding how many patients we have, how many nurses we currently have, and then using that information to decide and to really understand what we should be doing as well. And so we also discussed there what should we doing long term as well. So what should be the top priorities for further research and exploration? So another poll here. Should the bladder cancer community and national policymakers invest in opportunities to grow the workforce of bladder cancer healthcare professionals, especially CNSs? The value of expanding nursing roles focused on patients in the community should be considered, particularly with stoma management. The importance of different subspecialisms by urology CNSs should be recognised, with all major centres having a lead bladder cancer CNS. Or the bladder cancer workforce should grow at a rate that is able to cope with additional demand generated by improvements in the service pathway. I'll give you a few more seconds to answer that. And here, what came up as the top result was the bladder cancer community and national policymakers should invest in opportunities to grow the workforce of bladder cancer healthcare professionals. Grow the workforce. And one final question that we have from a patient is Susan says, in response to Tracy, she received the comment that bladder cancer is not fashionable, and this hit hard for her as a patient. Even when high-profile patients are diagnosed, we simply do not talk about bladders. I believe by persistently raising awareness, then over time we will raise the profile. Also, does the panel feel that this is not due to as many people who are diagnosed each year as, say, prostate, breast cancer?
I'd really like to have some insight myself on that. It's a really good question, and what I understand is that people who have been high profile, people with bladder cancer, have been asked to share their story, but then for whatever personal reasons they don't come forward. So I actually haven't got any insight onto that.
Yeah, I've not heard of any high-profile person with bladder cancer. It's just that they're not coming out there, I guess, and I don't know why that would be. because you do get it for most of the cancers. So.
Thank you, Heather and Juliet. Yes, and I'm so pleased that we've got so many patient advocates on this call as well, because I know that we've got a lot of patients who've done a lot of work sharing their story as well, and I think that really helps. Even if you're just sharing your story in a local newspaper, a lot of people are hearing those stories, and I think that is making a difference. So, we might not have one huge high-profile bladder cancer patient, but we're lucky enough to have so many different bladder cancer patients who are sharing their stories throughout their community, and that's wonderful. We're also getting a comment here from Mohini from the Royal College of Radiology that having managed prostate, breast, and bladder cancer, she sees that the patient voice is much louder in prostate and breast cancer, with very active, influential charities supporting the work of Fight Bladder Cancer. Please continue to raise and advocate the patient voice. And absolutely, Mohini, that's exactly what we're doing. So to summarise this session too, we've heard that breaking bad news better is definitely a priority, and that nurses can be one of the people that can deliver that. That everyone needs a CNS, because CNSs ensure that you're not going through this patient journey alone. That there are many different capacity issues. That there's over 33 titles for urology nurses and urological nurses around the country, and that can be very confusing. That there's a need for administrative support. That we heard that in 2014, when we looked at prostate cancer, 50% of nurses were planning to retire by 2024 due to retirement. So we need increased investment in CNSs. We need more training. We need a greater emphasis on holistic needs assessment. And we also talked about how at each point in the exemplar pathway, we can identify the CNS touch points, and that can also help us identify exactly how many CNSs we need. The dream is to have a whole team that looks after bladder cancer. So you've got a multidisciplinary team of different specialists who work together to support the patient. And we also need to continue our work to inspire the next generation of CNSs, so they can see how amazing and rewarding it is to work in bladder cancer, and how they should definitely focus on that as a specialism. And we should give them all the education and training resources that they need for that. We also polled the audience, and the audience said that in terms of short-term goals, mapping the number of CNSs was a priority, and in terms of longer-term goals, ensuring that we can grow the workforce to support the CNSs and the other members of the team that are needed to ensure an optimal pathway.